Presentation is about the academic session. From the academic session is about the hematuria, its evaluation and the management. And we will discuss the topic regarding microscopic hematuria, symptomatic and asymptomatic, and gross hematuria. And let's start it. And आगे चलते हैं, Dr. Pence.
Yeah. So basically, hematuria came from Greek word that is a hema, which means blood, and urine, to refer the presence of blood in urine. So hematuria is defined as the presence of at least 5 RBCs per high power field in 3 of 3 consecutive centrifuge specimens obtained at least 1 week apart. A diagnosis of hematuria is confirmed by a demonstration of RBCs in the urinary sediment as shown by the qualitative and quantitative microscopy. So
before we jump into the causes of the hematuria, go back to the first slide. From there, sitting residents, and from here, sitting residents, I just want to ask that once a patient came in emergency with the complaint of hematuria, what are the things that you look at, how you proceed for the case, and what are the things you look for the patient? Dr. Sapir, he is from the primary resident of urology from Sakhar.
Yeah.
एक पेशेंट आपके पास हेमेचूरिया से आता है इमरजेंसी में ना, आप उसको कैसे प्रोसीड करते हैं? व्हाट आर द थिंग्स यू लुक फॉर इन हिस्ट्री एंड फिजिकल एग्जामिनेशन?
History taking, we ask patient if it is during micturition bleeding, before or after.
What are the significance? What are you thinking about it?
If it is before micturition, bleeding probably from distal urinary tract, and if it is during micturition, so it is probably from proximal urinary tract.
Okay, it's a broad concept. Okay. Other than that, what things you should ask about the patient from history?
We ask the related questions like pain during micturition.
Painful है, painless है, good. और
significant weight loss as well.
जैसे टॉपिक है कि ग्रॉस है या माइक्रोस्कोपिक है. और Dr. Hakim, you want to add something?
History of trauma, painful or painless, and ask about the micturition at the start of the hematuria at the start of the micturition, during micturition, or at the end of the micturition.
Okay.
And history of UTI, history of stone disease.
What are the other questions related to hematuria? There are like several questions you should ask about hematuria when patient come to you.
History clots, or history of retention of the urine.
Due to the clots retention. Yes.
Any anticoagulant.
Good.
Use of anticoagulants.
Good.
And
what are the common causes? You think about the causes and then you investigate or ask in specific from the history. Tobacco use, you would ask about that. And वहाँ पे हैं Dr. Fez, residents, if they want to add something.
Anyone from here? You want to add something? Dr. Midha?
Just the initial thing, the patient comes to you, what things you look for in hematuria patient? I just want to know the mind of the residents. Just ask anyone. The things they have missed, if they want to add something from it.
Jiti madam.
And just quick because we just have now 20 minutes.
ड्यूरेशन पूछूंगी मैं पेशेंट से कि कितना ड्यूरेशन हुआ है मत पेन और इसके अलावा मैं पूछूंगी कि इसके साथ एसोसिएटेड सिम्टम्स और क्या हैं इफ इट इज एसोसिएटेड विद लोअर ट्रैक यूरिनरी सिम्टम्स और नॉट पेशेंट के क्रॉनिक चलते हुए आ रहे हैं और पेशेंट की स्टोन पैसेज की हिस्ट्री रही है या नहीं रही है, पेशेंट के ये हेमेचूरिया फीवर और बर्निंग मिक्सचरेशन के साथ एसोसिएटेड है या नहीं है। और
So every time you ask for the patient, you would always start from their demographics, like age क्या थी patient की, वो आपको बहुत ज्यादा सिग्निफाई कर देगा कि वो कौन सी वाली डिजीज से प्रेजेंट कर रहा होगा, मेल है या फीमेल है, जेंडर के हिसाब से। दूसरी चीज ये आ जाती है कि फिर पेशेंट ग्रॉस हेमेचूरिया है और माइक्रोस्कोपिक हेमेचूरिया है। यू वुड ऑलवेज आस्क इन ईआर कि आप एक यूरिन का सैंपल लेके आइए, और उसमें आपको इवेलुएट हो जाता है कि ग्रॉस हेमेचूरिया के साथ आ रहा है या फिर नहीं आ रहा है। फिर आप आगे से ये वाली सवाल पूछते हैं कि सिवेरिटी क्या थी, ड्यूरेशन क्या है, क्लॉट पैसेज थी, पैसेज के साथ नहीं थी, रिटेंशन में गया उसकी वजह से या नहीं गया, कोई इंस्ट्रूमेंटेशन की हिस्ट्री तो नहीं थी। जैसे डॉक्टर सफी, डॉक्टर हाकिम बोल रहे थे यहाँ पे कि पहले हो रहा है, इनिशियल मिक्चुरेशन है, ऑल द टाइम ड्यूरिंग मिक्चुरेशन है, और द टर्मिनल मिक्चुरेशन है। सो दीज आर द क्वेश्चन दैट यू हैव टू आस्क विद द माइंड कि वहां पे कौन सी ऐसी इस वक्त पैथोलॉजी चल रही है जिसकी वजह से एक हेमेचूरिया की एपिसोड एक पेशेंट को हुई है, बिकॉज दिस इज अ वेरी रेड फ्लैग साइन इन यूरोलॉजी। सो डॉक्टर फैज, कंटिन्यू नाउ प्लीज।
Excuse me?
या कंटिन्यू विद द प्रेजेंटेशन।
So coming towards causes of hematuria, first there are renal causes and ureter causes and lower system, that is bladder, prostate and urethral causes. In renal causes, there may be benign renal masses, that is the angiomyolopomas, oncocytoma or NEFCs. Malignant renal causes, that is renal cell carcinoma, transitional cell carcinoma, glomerular bleeding, IgA nephropathy, thin basement membrane disease, and there may be structural diseases, polycystic kidney disease, medullary sponge disease, pyelonephritis, hydronephrosis, or hypercalciuria. In utero, there may be due to malignancy, stone, or any kind of any structure in the lengthwise, and post-surgical conditions like ureteroileal fistula. In bladder, there may be due to any underlying malignancy, or after radiation, or due to inflammation, cystitis, and bladder stones. In prostate and urethra, maybe due to benign prostate hyperplasia, prostate cancer, or any prostatic procedures, any traumatic catheterization, or any urethral diverticulum. So major causes of hematuria by the age and duration, coming from a transient to persistent. That is transient unexplained urinary tract infections, or there may be caused stones, or exercise. In exercise, we also see the hematuria, trauma, and endometriosis. In sickle cell diseases, there may be cases that we see hematuria. So in polycystic kidney disease also, coming towards persistent, there may be due to cancer of bladder, kidney, or prostate. So there are some other kind of terminologies that we observe here. That is cyclic hematuria. In women, and that is most prominent during and shortly after menstruation, suggesting endometriosis of the urinary tract, or sterile pyuria with hematuria. It's mostly occur in renal tuberculosis, analgesic nephropathy, and other interstitial disease. Hematuria dysuria syndrome. It is the presence of hematuria and dysuria after gastrocystoplasty, most likely due to acid irritation. Nutcracker syndrome, as it is the compression of left renal vein between abdominal aorta and superior mesenteric artery. This can also lead to renal venous hypertension that result in rupture of thin-walled veins into collating system that result in hematuria. So coming towards classification of hematuria, According to visibility, we can say that it is a gross hematuria or microscopic hematuria. And according to presentation, it may be painful or painless. The timing of hematuria, that is early initial hematuria, terminal hematuria, or diffuse, which that is a total hematuria. So the early hematuria, and there may be urethral origin or distal to external sphincter. In terminal hematuria, that may be due to bladder, neck, or prostatic origin. Or in diffuse hematuria, source in bladder or upper tract. So coming towards microscopic hematuria. Macrohematuria, also called microscopic hematuria, is a medical condition in which urine contains small amount of blood. The blood quantity is too low to change the color of urine. At the same time, it has been microscopic hematuria is caused by significant medical conditions such as urinary tract malignancy. So malignancy has been detected in approximately 3.5% of patients evaluated for asymptomatic microscopic hematuria. The AUA recommends the definition of microscopic hematuria as 3 or more RBCs per hyperfield in urinary sediment from 2 of the 3 properly collected urine specimens. According to guideline statements, and the clinical should not define microscopic hematuria by positive diagnostic test alone. A positive urine diagnostic test should prompt formal microscopic evaluation of the urine. A chemical test for hematuria detect the peroxidase activity of hemoglobin using benzidine, and therefore conditions such as myoglobinuria can falsely activate the test. So positive diagnostic test that does not warrant full evaluation unless microscopy confirm the presence of 3 or more RBCs per high field power. False positive, a specimen collected immediately after prolonged recumbency or after vigorous physical or sexual activity may be falsely positive for hematuria. False negative, dilute urine, that is osmolality less than 308, may result in false negative microscopic examination as a result of RBC's lysis. Urine cytology. Cytology is the most useful in the detection of high-grade malignancy and is positive in 90% of the cases. In low-grade tumors, it is positive in only 10% of the patient. So, how to perform it? If anyone knows. Urine cytology is. Yes, madam.
साइटोलॉजी के लिए आप सैंपल कैसे कलेक्ट करते हैं? ठीक है, कहाँ पे कहीं पे?
Urine cytology is performed on a random or ideally a mid-morning urine sample. Early morning urine sample provide degenerative specimens for cytological examination. The sample should be whole voided urine or as an mid-stream urine. Ideally, at least 3 mid-morning or random specimens should be submitted for examination, but this is often impractical. Catheter specimen can be utilized, but cellular changes may be seen with this method of collection.
थोड़ा सा मैं आपको पीछे जाइएगा. The method of doing cytology is the mandatory volume of urine should be 100 ml. So if there is a situation in which it falls below 100, what you can add is something which is normal saline. So either you flush the bladder with normal saline and take that 100 ml of returned fluid as having some of the cells which are denuded from the surface lining of the bladder, or you have 100 ml of urine collected within the bladder. Now that urine sample is then subjected to centrifuge, Now, when the centrifugation is done, as a result of that, the cells are separated from the supernatant and the cells become something of value. And then they are seen through different techniques under microscope for ploidy, for pleomorphism, for mitotic figures. So this is how this should be done. And it is something which everybody should know, right up from the resident level up to the level of senior people. So it is nothing which should be known by somebody who is interested in the field. It is a procedure which should be known to everyone who claims to be a urologist.
So how to investigate? There are different guidelines. According to AUA guidelines, if a patient is adult, then criteria for evaluation is 3 or more RBCs on a single urine analysis, and cystoscopy if age greater than 5 years old or with risk factors. Imaging maybe CT urogram preferred. Biomarkers that are not recommended. According to Canadian consensus document, patient age adult, criteria for evaluation 3 or more RBCs per high power field on 2 out of 3 urine analysis, and cystoscopy is recommended if greater than 35 years old. Imaging provided is discretion, and biomarkers not recommended. According to Kaiser Permanente, more than 3 RBCs per high power field on 2 out of 3 urine analysis. Cystoscopy is according to urologist's discretion, and in imaging CT urogram or IVP plus renal ultrasound. According to American College of Obs and Gynecologists and American Urogynecological Society, if adult age is adult women are criteria for evaluation that is not stated still. Avoid in never smoking women age 30 to 35 to 50 years. Only evaluate if greater than 25 RBCs per high power field. So avoid in never smoking women age 35 to 50 years. Only if evaluate if greater than 25 RBCs per high field in imaging. So according to Japanese, if age is greater than 40 years old, and criteria for evaluation is 5 or more RBCs on a single urine analysis, and for cystoscopy age 40 or greater than 40 years old with risk factors, and in imaging we do ultrasound, and biomarkers plus minus. According to Dutch, if age is greater than 50 years, then criteria for evaluation is 3 or more RBCs on 2 out of 3 urine analysis, and for cystoscopy the age should be greater than 50 years old, provided discretion in younger patient. And for imaging, ultrasound if greater than 50 years old, provided discretion in younger patients. And for biomarkers, cytology recommended in patients with negative evaluation. According to American College of Physicians, if a patient is adult, for criteria 3 or more RBCs on a single urine analysis, cystoscopy not stated, and imaging and biomarkers not stated. So coming towards the next topic, how to approach or select patient for evaluation for hematuria. In patient with microscopic hematuria, clinician should perform first the history and physical examination to assess the risk factors for genitourinary malignancy and medical renal disease, gynecological and non-malignant genitourinary causes for microscopic hematuria. That is clinical principle. And clinicians should perform the same evaluation of patient with microscopic hematuria who are taking antiplatelet agents or anticoagulants as those patients who are not taking these agents. That's a strong recommendation and evidence level grade C. In patient with finding findings suggestive of gynecological or non-malignant urological etiology. Clinician should evaluate the patient with appropriate physical examination technique and test to identify such an etiology. It is also a clinical principle. In patient with hematuria attributed to any UTI, clinician should obtain urine analysis with microscopic evaluation following treatment to ensure resolution of hematuria. It's also a strong recommendation and evidence level is grade C. Clinician should refer patients with microscopic hematuria for nephrological evaluation if medical renal disease is suspected. However, risk-based urological evaluation should still be performed. It is also clinical principle. Following initial evaluation, clinician should categorize patient presenting with microscopic hematuria as low, intermediate, or high risk for genitourinary malignancy based on the accompanying tables. There is a strong recommendation, evidence level, and grade C. In low risk patient with microscopic hematuria, clinicians should engage in patients in shared decision making to decide between the repeated urine analysis within 6 months or proceeding with cystoscopy and renal ultrasound. In low risk patients who initially elected not to undergo cystoscopy or upper tract imaging and who are found to have microscopic hematuria on repeat urine testing should be reclassified as intermediate or high risk. In such patient, clinicians should perform cystoscopy and upper tract imaging in accordance with the recommendation for these risk stratifications. Clinicians should perform cystoscopy and renal ultrasound in patient with microscopic hematuria, categorized as intermediate risk for malignancy. And for high-risk patient, clinicians should perform cystoscopy and axial upper tract imaging in patient with microscopic categorized as microscopic hematuria is categorized high risk for malignancy. If there are no any contraindication to its use, clinicians should perform multiphasic CT urography. If it is contraindicated, then clinician may utilize MR urography. If these two are contraindicated, then clinician may utilize retrograde pyelography in conjunction with non-contrast axial imaging or renal ultrasounds. Clinician should perform white light cystoscopy in patient undergoing. So the differential diagnosis of gross hematuria remains the same as for microscopic hematuria. However, as the degree of hematuria increases, so does the likelihood of finding clinical significant lesions during evaluation. Among patients with gross hematuria, 50% have been found to have demonstrable causes. 20-25% have been found to have urological malignancy, most commonly bladder and kidney cancers. Patient presenting with gross hematuria in the absence of trauma or any cultural documented UTI should be evaluated with urine cytological examination, cystoscopy, and upper tract imaging, preferably by CT urogram. The initial assessment for patient with gross hematuria should include history, physical examination, and laboratory studies. So the evaluation of adults with gross hematuria. When patient came with gross hematuria, the first thing is urine analysis with microscopy to confirm the presence of hematuria. Does the patient have 3 or more than 3 RBCs? If no, then hematuria are not present. And if yes, then hematuria confirmed. If there are visible blood clots present in the urine, if no, does the patient have acute onset, unilateral or flank pain? Then if it is no, then are any of the following these things are present in patient? That's the patient symptoms of UTI or urine RBCs and positive urine nitrite. If no, then evaluate patient for other medical causes such as for proteinuria, acute rise in serum creatinine, RBCs caused, or dysmorphic RBCs, and new or worsening hypertension, or new or worsening edema. So if on examination and cytology or urine analysis hematuria confirmed, then refer the patient to emergency department if symptoms of urinary obstruction or retention are there. Order CT urography urgent and urological reference for cystoscopy. If patient have any acute onset, then refer patient to emergency department for evaluation of nephrolithiasis. If on urine culture there are urinary tract infection, if it is positive, then treat according to UTI and repeat urine analysis with microscopy in 6 weeks. If again there are present in hematuria, then evaluate for other medical causes that we have discussed earlier. If there are no hematuria, then no further evaluation will be required. So take home message. Every case of hematuria requires investigation. Macrohematuria requires more extensive investigation. Because of a lack of high quality scientific evidence, there are no consistent guideline recommendations for the investigation of hematuria, especially asymptomatic microhematuria. For a basic investigation, for all patients, IST should be taken and clinical and laboratory tests carried out, and possibly also red cell morphology studies and renal and bladder sonography should be done. Patients who have been exposed to exogenous toxins, including tobacco smoke, or older, or male sex gender, and have macrohematuria should be further investigated by urethrocytoscopy and perhaps CT urography. Thank you.